the senior international cardiologist and cath lab director, Care Hospital, Banjara Hills. And actually, today we want to discuss the advanced lipid lowering therapy and aggressive lipid lowering therapies, especially with the availability of the biological molecules, especially the new insights with PCSK9 inhibitors, not only circulating but also hepatocyte PCSK9 inhibitor, that is inclisiran. Today we want to know some of the fewer aspects so that we can have some advance in the management so that we can reduce the burden of atherosclerotic cardiovascular disease in the population. So today we can have some common questions so that we can answer and that clarify the doubts, especially for the practicing clinical physicians or healthcare providers. So I first of all, I'm at the outset, I'm thankful to the JB Chemicals for giving this opportunity regarding the educational platform to exchange the information, education information among us regarding the inclisiran, that is the newer molecule, that is small inhibitory mRNA molecule. This is most important. These are the one of the common things which we encounter in our day-to-day practice. And Indians have a higher CV risk and experience early cardiac events in our day-to-day practice. Indians, by virtue of their hereditary nature and lipoproteinuria molecules and ethnic nature of central obesity, metabolic syndromes, we have higher incidence of the dyslipidemia and cardiovascular risk. So elevated LDL-C levels are crucial due to their strong and linear association with ASCVD risk, that is atherosclerotic cardiovascular disease. Each 1 millimole per liter, that is 35 milligrams per deciliter decrease in LDL, associated with 21% reduction of the major cardiovascular events. So this is very, very important. Linear relation is there with cardiovascular risk and LDL levels. So later, the guidelines that is recommended to strike early and strike strong. These two are very, very important resonant terms, especially for treating physicians as well as the cardiologists. The lower is the better. Very, very important. This we should know everybody, because the 2023 ESC guidelines and the CSI 2023 guidelines, if you see the very, very extremely high cardiovascular risk, they should have a target level of at least a reduction to more than less than 50%, 50 milligrams percent in very high risk patient. In extremely high risk, LDL should be less to the 50 milligrams, especially Indian setting, LPA guidelines, it should be less than 40 milligrams percent, also even less than 30 in very, very extremely high risk patients. So with this, these are the some of the events. Lowering of LDL, whether it is safe or not, that is also most important, especially the LDL-C as low as 10 milligrams percent also, there is a safety concerns is there, no side effects and no long-standing treatment with a cognitive defect. And as we know, the inclisiran mimics the body's process of RNA interference, which is restricted to the cytoplasm. So conjugated with GalNAc for specific uptake by hepatocytes, low likelihood of off-target binding. So that means only specifically targeted binding of LDL receptors will occur, and inclisiran plasma levels decline within 24 hours and are undetectable within 40 hours. So once you stop, it will be undetectable within 48 hours. But the mechanism of action will persist up to almost 6 to 8 months. Next slide. So this is important. So Indian approval for approved indications are, it is indicated in adults with primary hypercholesterolemia, especially heterozygous familial hypercholesterolemia and non-familial hypercholesterolemia, which is very, very prevalent in the population as a hidden factor, or mixed dyslipidemia also as in adjunct to the diet. In combination with the statin or statin with other lipid-lowering therapies in patients who are unable to reach LDL-C goals, will have a maximum statin doses, still it is not effective means, then you have to supplement with inclisiran. Alone or in combination with other lipid lowering drugs also you can use, especially for other lipid lowering therapy, especially when statin intolerance is there, then this is a very useful drug in reaching the ideal goals. It is a suitable patient profile if you take. It is useful in high cardiovascular risk individuals with atherosclerotic cardiovascular disease whose high LDL-C levels remain inadequately controlled by statins lowering drugs or HTMB or bempedoic acid, and it is also used in the treatment of heterozygous familial hypercholesterolemias. The recommended dosage is 284 milligrams inclisiran administered as a single subcutaneous injection initially, then at 3 months, followed by every 6 months. This is important actually. The injection is almost, it contains 1.5 ml and with a pre-filled syringe, 300 milligrams inclisiran sodium will be there, water as a diluent, sodium hydroxide and phosphoric acid and pH of 7, stored at room temperature. And dosage interval, if you take the initial injection, the second dose you have to take at the end of 3 months, and then subsequent every 6 months, it will maintain the adequate LDL levels as low as 10 milligrams percent in a very stable way. Actually, this is important actually. And this is the evidence of this one is by means of Orion studies, which are landmark studies showing the efficacy of inclisiran in reducing the LDL-C levels, not only the reduction of LDL-C level, but also a clinical transformation reduction of the ACDV or major cardiovascular risk events. Next slide. This is important. So, if you miss the dose, then it is missed by less than 3 months. Inclisiran should be administered and dosing continued according to the patient's original schedule. If you miss, if a planned dose is missed by more than 3 months, a new dosing schedule again you have to start, and it should be administered initially again at 3 months, again 6 months. And treatment transition for monoclonal antibody, that is a evolocumab to PCSK inhibitors, is can be administered immediately after the last dose of monoclonal antibody PCSK inhibitor. To maintain LDL-C lowering, it is recommended that inclisiran administered within 2 weeks after the last dose of a monoclonal antibody. As we know, the circulating maps for PCSK inhibitor is usually 2 weeks. It's a half-life. So within 2 weeks of that monoclonal antibody administration, then if you can give inclisiran, that lowering of lowered LDL will be maintained sustained way. Sustained low LDL will maintain level, it will be maintained so that the new onset MACE events won't occur and LDL-C levels will be maintained below 40 milligrams or 30 milligrams per second. So this is the management algorithm, which is very important. Usually what happens in ACS patients, once you control or undergoing the angioplasty with the high dose statins and all these things, then the target LDL you have to see. If it is less than 55 milligrams percent, you can continue. Whereas suppose if lipid at the end of the 4 weeks and LDL-C still more than 55, then you can add bempedoic acid. Even after bempedoic acid also still it is LDL-C is high means, then that is indication for the PCSK inhibitors, so that your LDL-C goals should be less than 55 milligrams percent will be as per the European Society of Guidelines or Cardiology Society of India guidelines. Next slide. This is important. Actually, the hereditary familial hyperlipidemia patients, the most important is as per the guidelines, whether without the cardiovascular disease, the goals are different. With cardiovascular disease, goals are different. With cardiovascular disease, they comes under high risk and very high risk. Whereas without CVD, it comes under the medium risk, and just risk factor means it is a low risk. So the targets also it vary. For secondary preventions, once means established means always they are under a very high risk or extremely high risk patient, where the target LDL should be less than 55 milligrams. Yeah, depending upon the target levels, whether you get add to these PCSK inhibitors or not. You have to take a decision. Next slide. So this is a complex algorithm, as we know, which explains the same thing. Most important is the target LDL, then the risk factor, then most important, apart from the lipid profile, the lipoprotein A molecule also very important, which you should get, because statins won't have control, and bempedoic acid also has no effect on lipoprotein A molecule, and only thing which has lipoprotein molecule is PCSK inhibitor, especially either MAPS or the inclisiran molecule, which has more efficacy in reduction of the lipoprotein along with the LDL, more than 50 milligram per reduction. So these are the landmark trials, Orion 9, Orion 10, and Orion 11, where it was studied Orion 9 on hereditary familial hyperlipidemias, whereas Orion 10 is atherosclerotic cardiovascular disease patients, and Orion 11 is a established atherosclerotic cardiovascular disease or atherosclerotic cardiovascular equivalents, which was studied in the Western world. And the dosage is 300 milligrams of inclisiran sodium, equivalent to 284 milligrams of inclisiran, matching placebo, administered subcutaneously. And then the treatment period is up to 18 months. Then the status, it is complete, the study period is completed. Next slide. Next slide. So this is a pooled analysis of the Orion 9, 10, 11 trials, which has ultimately the graphical depiction, which was shown that almost sustained LCLC reductions are achieved in 50.5%, and effective LDLC reduction is 50.7%, which is a very, very significant figures. So which is matching with the guidelines demonstrating the goals, LDL goals. So with inclisiran as strong complement to the maximally tolerated statin, 68% of it achieved LDLC of less than 70 milligrams per cent, and 52% achieved less than 50 milligrams per cent, especially in high risk and extremely high risk, which is desirable as per the guidelines. Next slide. This is important. Actually, if you take the median percentage of change of lipoprotein A molecules from baseline over the time, and geometric mean lipoprotein A ratio, if you carefully see, almost the placebo adjusted mean percent reduction of LDLC from baseline with inclisiran is 57.2, whereas the ratio of LPA to baseline was approximately 41%, indicating very, very, very significant LPA reduction compared to even MAPS, evolocumab, compared to placebo and evolocumab, where the statistical value is more and significant, and this is suitable for Indian population, where lipoprotein A is one of the independent risk factors, enhances the side effects of LDLC in increasing the atherosclerotic cardiovascular disease events. Next slide. This is important slide where changes the lipid parameters at day 5 if you take the population lipoprotein A, 8, and non-HDL cholesterol, triglycerides, lipoprotein A, and HDLC if you take all the, especially ApoB and non-HDL cholesterol are, and total cholesterol is significantly less, that is less than 0.00, which is statistically significant. Next slide. And this is also important. Treatment emergent, that is also safety. Also, you have to see adverse events. If you take serious adverse events are almost similar between inclusion and placebo groups, except for ISR, and more participants experience these inclusirans in the inclusion group 2, predominantly mild and transient. None were severe, but especially local reactions. If you take that is frequent adverse events are almost similar between placebo and inclisiran, except for local injection, some mild rash, which is tolerable and which is insignificant. This is also important because low LDL, if you're maintaining any lot of concern regarding the cognition and neurological side effects also we have to see. So what is the evidence is saying? Yes, it is well-traveled long-term safety data, proven up to 6.8 years of exposure, and Orion 8, which is a safety data, open-label extension trial of Orion 3, 9, 10, 11, 9 and 10, 11 of almost 3,274 patients, participants, long-term efficacy and safety of twice-yearly inclisiran therapy of patients of high cardiovascular risk with elevated LDL-C showed inclisiran could reduce LDL-C levels in the long term while being well tolerated. No cognitive or neurological side effects also. It acts in the cytoplasm and hepatocytes, not in the nucleus. So there's no risk of carcinogenicity or teratogenicity or immunogenicity. This is important point because the site of action is cytoplasm by means of translation of nonsense codons for the this molecule PCSK9. So which is ineffective. So upregulation of LDL-C receptor will occur, which will suck the LDL molecules in the circulating blood, so that it will be maintained as low as possible, which reduce the cardiovascular events. Next slide. This is also important. So results of Orion 8, which is the largest long-term safety and efficacy follow-up trial with inclisiran conducted to date, show the inclisiran could reduce LDL levels in long term while being well tolerated. This is important. Efficacy is maintained without having side effects. That is maintaining the safety also. This is important, especially in inclisiran group. And what is the cardiovascular outcome data with inclisiran? That's right. So this is important. Orion 4 and Victorian 2P are ongoing CBOT with the completion dates and anticipated 2027, which results are awaiting. As per the cardiovascular outcome data are ongoing, a recently published pooled patient label analysis showing 911, 91011 provides some insights into the possible cardiovascular benefits of treatment with inclisiran. Significant 26% reduction of the composite MACE events compared to placebo is documented over 18 months, and fewer MACE compared to the placebo. This is important. So, inclisiran having a significant reduction of the MACE events. And Mendelian randomization studies with 20 million person years of follow proven dose dependent long linear association between absolute magnitude of exposure to vasculature to LDL-C, the risk of it. This is important. So, as the duration of LDL sees more and more higher levels of exposure, more and more tendency for ASVD, the exposure is less and less, especially in familiar heterozygous hyperlipidemia, the incidence of ASVD is less and less. That's like